Okay, so thanks for coming. I'm B.Weeks. I'm from Dartmouth. And today I'm going to talk about work that examines geographic variation, like Bruno said, in the supply and use of hospital services in France. And feel free, if you have questions at any time, feel free to ask them. But for a moment now, I just want to thank the people who are sponsoring me to be here, the Fulbright Commission, Dartmouth, where I work, IMERA, and AMS. There's an E after that, AMS. So this research was motivated by economic theory that suggests that market forces in competitive markets should allocate scarce resources efficiently. But Kenneth Arrow suggested that this may not be the case in healthcare, right? And that factors such as inadequate regulation and oversight might make things not efficiently allocated in healthcare in particular. So we wondered, as part of this research, whether excessive geographic variation might reflect such deficiencies in France. This work builds on work at Dartmouth, where Jack Winberg works. I don't know if you've heard of him, but he's really kind of helped establish geographic variation, although there was someone in France in the late 1800s that did some work looking at mental health disorders in France, up in particular in the northern region. And Jack's work has been over 40 years. It was a seminal article in 1973 in Science that looked at geographic variation just in Vermont, and from that he's had books and hundreds of publications. And in that work he's defined three categories of healthcare services. The first is effective care, which is evidence-based, and it's what people should get. For instance, if you have a heart attack, it's generally thought that you should get beta blockers after you have a heart attack. That's protective for future heart attacks, and you should get that. Other examples are things like glucose blood testing and diabetes. And when we look at the US, we see that there's a lot of geographic variation in the proportion of people who get these effective treatments that are evidence-based. And in the US, across the US, about half of the people actually get effective treatments, which is not very good. And it's kind of sad, a big waste in our system. The second area is preference-sensitive care, and we'll talk about this care and supply-sensitive care. Preference-sensitive care is where you have a condition that has multiple treatment options that involve significant trade-offs. For instance, in where you might get medical treatment or surgical treatment, and it's up to patients' own decisions and preferences, kind of whether or not they choose one course or the other. So, for instance, if you have knee osteoarthritis, you might have a course of physical therapy and medications for pain relief, or you could get a knee replacement. And we found that in the US, there are other examples like hip replacement, a number of elective surgeries where it's not emergency, you have a condition, you make this decision to get the surgical condition or the medical treatment, and things like back surgery, hip surgery, prostate surgery. And studies indicate there's a lot of variation, geographic variation in per capita use of these services, and that's attributed to the fee-for-service system in the US that incentivizes overuse of care. So every time a physician does a knee replacement surgery, every single time they do one, they might get $4,000 or $5,000, and they can do 3 or 4 a day, and the more they do, the bigger house they get and the bigger yacht they have and things like that. So there's an incentive to do more of that. And it may be as well some physicians have different preferences for treatment, where they might take more conservative treatments and just not operate as much, and some might be very broad and have a very different threshold for treatment intervention. So the thought here is that actually involving patients in decision-making more and using shared decision-making tools and informed patient consent may reduce variation in preference-sensitive care. Finally, we have supply-sensitive care, and we'll look at this a little bit. This is where the supply of a specific resource, like the number of physicians per capita or the number of beds per capita, might influence the use of those services. And this might be as well a cultural issue because of different patterns in service use and expectations of the public. For instance, when there are more doctors per capita, you see that there are more visits per patient. in the US. And when there are more beds per capita, when there are more hospital beds, there are more admissions per capita in the US. Interestingly, there's one case where that doesn't apply, and that's what we're going to look at, is where there's ambulatory care sensitive conditions admissions. And that's these type of admissions. It's when it's for pneumonia, it's for things for a congestive heart failure exacerbation, for angina exacerbation. And these are conditions where it's believed that primary care intervention could prevent the hospitalization. So if they had adequate primary care, it could prevent the hospitalization. And here, so generally, when you see there's more physicians in the area, more primary care physicians, generally you see that there are fewer of these kinds of admissions. So we'll look at ambulatory care sensitive conditions in a bit. So the two areas that we're looking at, because until really recently, geographic variation in France has not been studied from a national perspective. Dr. Vergier, right, has studied some regional variations, right, in hospital service utilization and frequency of diagnoses and so forth, but nationally it just hasn't been done much in France. And so we began to look at variation from a national perspective, and we wanted to try to look at the knowledge deficit of the lack of information about national geographic variation and explore kind of two areas. The first is just hospital admissions for a number of surgical procedures that are these preference-sensitive types that I discussed, and where sometimes physicians can influence the amount of care that is obtained. In your case as well, we were interested because the newer evolution of the role of the for-profit hospitals in the US, it looks like for-profit hospitals do even more of these preference-sensitive conditions because they make money on them. And here we wondered whether that might be the same case as well. We kind of thought that because if we were to compare variation of these kinds of services in the US to France, that France might have less variation because it's a more centralized system than is the case in the US, and there's more broad access to care, and so you wouldn't have those access issues and the kind of Wild West that we have in the US when it comes to trying to get reimbursement. The second area, like I said, is these ambulatory care sensitive conditions. These are considered avoidable, and because they're avoidable, they could represent some cost savings to the French taxpayers, right? If you are using primary care more efficiently, you might avoid a really expensive hospitalization and also all the problems that go along with that, like patients getting sick in the hospital and so forth. So as I said, higher rates of ambulatory care sensitive conditions have usually been associated with lower supplies of primary care physicians, and we thought that perhaps we might find the same thing in France when we looked here. These are important research areas for three general reasons, we think. First, we thought that the work could identify particular procedures or geographic settings that were ripe for policy intervention. So just like in the last talk, if you found an area where people were just not prescribing, weren't giving the HPV, you might focus on that area first, right? It might be a good strategic move and an efficient use of resources to focus on an area where there's a problem. So if you can look at and identify an area that might be a problem, that might be a good thing. Also, if there's high level of geographic variation, that means that there's frequently in the literature it suggests that there's uncertainty as what the best practice is. So there you might use some academic detailing or develop some guidelines about what is the best practice and try to implement that to decrease the variation that you see, particularly in high utilization areas. Second, we were concerned that the recent policy changes that promote the competition between not-for-profit and for-profit hospitals might actually encourage overutilization, right? And so if the idea behind that was that the for-profit hospitals are paid less, and so if you can get the for-profit hospitals to do more of these surgeries, you can save money, assuming that you're doing the same amount. But if the for-profit hospitals are incentivized to do more, and they just do more, any cost savings you realize from fewer in the not-for-profit setting might be offset by cost expenditures on the for-profit setting where you're just doing more unnecessary surgery, right? So that was a concern, and we thought we could look at that. in that case, we thought that if we found that, there might be a reason to have increased hospital oversight, and that might be warranted. And finally, we thought that looking at reimbursements associated with these preventable admissions, the ambulatory care sensitive condition admissions, might help policymakers understand the size of the problem and get them kind of interested in studying geographic variation in general. So we used a number of data sources that Pierre said he's familiar with as well, right? And so these included a data set that includes all of the French admissions to French medical and surgical hospitals in 2008 to 2010, and that included patient characteristics like age and sex and their diagnoses and the reasons they were admitted and the length of stay as well. Then we looked at hospital characteristics. There was a data set that allowed us to determine which hospitals were for-profit and not-for-profit. We used the census to develop denominators so that we can then look at sex age-adjusted rates, because obviously places with bigger numbers of people will have more surgery, so we're looking at per capita utilization, and we need to adjust for the demographics that are different in those different populations and the different settings. And we had a data set that looked at resource supply, the number of physicians per capita, and the number of beds that we were able to make into a per capita number, and then the reimbursements at the group, the GHM, or which is similar to the DRG method that we use in the U.S. It combines different groups of reasons for hospitalization for compensation purposes. So what we tried to do is we mimicked the Dartmouth Atlas methods and tried to age, sex, adjust department level rates for the 94 departments that are just in mainland France. So we didn't look at Corsica and we didn't look outside of mainland France. And we used these rates to calculate 4 measures of geographic variation that reveal the degree to which geographic variation is existing, and for the different admissions that we examine. And these 4 are the extreme ratio, and this is a simple calculation. You look at the 94 different rates, you take the highest rate divided by the lowest rate, and that's a number. And so where the number is higher, obviously there's more variation. There's a bigger difference between the lowest and the highest. The interquartile ratio, where you look at the 25th and the 75th percentile, and you divide the 75th by the 25th, and that gives you another indicator, a little narrower indicator of variation. We also looked at the systemic component of variation, which is something I'll get to in the next slide that I'll explain to you a little bit, that allows for cross-national comparisons. We looked at the literature, and where the data were available, we could make some comparisons of French results to results from other countries. That was much more robust in the ambulatory care sensitive condition analysis. We used linear and spatial regression techniques to explore associations between rates and department level variables like the population density, the median income, and medical resource supplies. And we consider differences in the way that the for-profit and the not-for-profit hospital sectors in France provided care, and then calculated reimbursements associated with the care provided using that DRG methodology. So the 2 specific methods I wanted to elaborate on a little bit was a systemic component of variation, and that was developed to allow for comparisons of geographic variation across countries. There are 2 problems if you were just to use, for instance, a standard measure of variation. The first, the variance and the standard deviation are influenced by the scale of measurement. So comparisons across countries with very different overall per capita utilization rates would be biased. And second, the coefficient of variation, which is a common method of looking at variation, right, is influenced by underlying population size. And so that's going to be really large if sampling error is the dominant source of variation. So if the underlying population sizes of the relevant geographic settings were different, the comparison across the countries would be, again, they would be biased. And so we wouldn't want that. So the systemic component of variation is adapted from a proportional hazards model and estimates the geographic variation around a national norm. So it kind of standardizes and creates a national norm that gives you some variation around that and allows for differences in prevailing rates then and also population denominators. The interpretation of the systematic component of variation is standardized, so if it's above 5, it's high variation, and above 10 is really very high variation. Second, we use spatial regression techniques. So beyond just linear regression, right, the idea is that regions in proximity to one another may influence one another because of maybe cultural differences or just the way people practice, or people cross borders to get care, and so do the providers. So what we then use is a method where if the observations that are closest to each other have related values, the OLS assumption of independence of variables is violated. So spatial regression accounts for this by specifying values at the nearby geographic locations and then weighting them according to a matrix that can be based on distance or just proximity, or just touching, the thing. So the process that you use is you run a OLS and then you test for autocorrelation. If you find spatial dependencies that are significant, you use a spatial regression model that includes a spatial lag term and specifies and weights values at nearby locations according to this matrix. And you can get it actually for free at GeoDay, which is a good use of this. And it didn't really change our results all that much, really. So first we'll look at geographic variation in hospitalization for elective surgical care for preference-sensitive conditions. And I'm just going to show you how I'm demonstrating variation. This box shows the 75th and 25th percentile of the per capita age-sex adjusted rates for each particular procedure done for each year, okay? And in some places we also have it for different age groups. So this is the 75th and 25th percentile. The horizontal line is the 50th percentile, the median, and the open circles are the high and the low for a particular region. So this is the lowest rate in a particular region. This is the highest of all the regions, I guess, for a particular year, for a particular condition, and for a particular age. All right. And this then, so this is a busy slide, but we looked at, this is CABG, spine surgery, radical prostatectomy, which is when you take out the entire prostate. It's an open procedure. It's different from the so-called TURP, which is more of a roto-rooter kind of a thing. A coronary endarterectomy, colectomy for cancer, a hysterectomy, and this is a cholecystectomy. And we have PCI, hip replacement, knee replacement, TURP, and then hip fracture. And the reason we look at hip fracture is because hip fracture, one would think, should not have geographic variation, right? When people get a hip fracture, everyone goes to the hospital. And that's in the US, it's here. It's kind of just generally the way that you provide care. So you use that as a nice indicator just to see if the model's kind of working and to show that, in fact, there's not geographic variation for that. And so this just shows these different procedures, and this is the age 65 to 99, 45 to 64, and the younger age groups where we also look at cesarean section and tonsillectomy. Obviously, cesarean section and hysterectomy are just for women. TURP and radical prostatectomy are just for men. And these are the rates that we generate. And you can see, you can see that there are some instances where things are going kind of down over time. This is time 2008, 9, and 10 in each kind of section here. So the median is kind of going down here with CABG and with radical prostatectomy. You see radical prostatectomy has a very high ratio of the extreme ratio, where there's a very high upper end and a very low lower end, right? And you can see these kind of, if you can imagine these kind of going up here. Some are more stable and some change over time, and the patterns change a little bit according to age. And I'll just run through some of these patterns for you quickly here. So you can see there's a fair amount of variation. If there were no variation, it would just be flat, and you can actually kind of see this over here, right? You see how the high and low is kind of tight, and there's not a lot of variation. The boxes are small in hip fracture, right? So that's kind of that would be a low variation example, and we'll get to that in a minute. Knee replacement is maybe low variation in the 45 to 64 age group, but higher variation in older age groups. So here we have, just to show you the spine surgery has the rates of procedure were kind of lower in the younger age groups, except for spine surgery, which was more similar, and also hysterectomy, which was actually higher in the younger age group, which you would kind of expect, right? In the 45 to 55 age group is going to be more common. We see that there are some CABG, radical prostatectomy, hysterectomy. This is radical prostatectomy in the younger age group, and CABG and hysterectomy in this age group. These are all kind of going down with time over 3 years. Actually, there's kind of a fair amount of movement in 3 years in rates overall. While others are going up, things like spine surgery is going up. Cholecystectomy is going up in here and here. Hip replacement and knee replacement are going up. PCI is going up in the older age group. Tonsillectomy kind of moved upwards, which should be a little concerning because there's more and more evidence that that shouldn't happen so much. And hysterectomy, even in younger age groups, is going up. So there's a lot of variation, there's a lot of movement in these over just a really short time period. This just shows that it compares the per capita rates of these surgeries to those in the US. And because in the US we only calculate them for 65 and older, I'm just showing you the older than 65 in the French setting as well. And so here's the line of equivalence, right? 2 and 2 crosses here. This is the rates in France. These are the rates in the US. And so if they're to the right of this line, France has a higher rate. If they're to the left of this line, France has a lower rate, per capita rate, age, sex adjusted in the two countries. And you can see that France has kind of higher colectomy rates and hip replacement rates, and also a little bit higher hip fracture rate, which was a little surprising. I would have thought it would be the same, but particularly because the French walk a lot more than we do in the US, I would have thought that'd be more robust. Where there's a high degree, if you looked at the previous slide and the next one, these CABG, prostatectomy, carotid endarterectomy, and spine surgery have higher rates of variation, higher standardized rates of variation, and we see that, and that they're lower rates in France. They're kind of common rates in here, and there's a much more variation in the U.S. in these conditions. So this is looking at these 4 different measures of variation that we did: the extreme ratio, interquartile ratio, coefficient variation, and systematic component of variation for each of these. And you can see that hip fracture is where it should be, right? It's the lowest one. It's got the lowest extreme ratio, very low interquartile ratio, and a low, really, really low systematic component of variation. So indeed, that you wouldn't expect people, to have different rates of hip fracture necessarily across different areas. What we did find, remember, 5 is the cutoff for high and 10 is the cutoff for very high, and we found that France has a fairly high degree of geographic variation for 9 out of the ones that we examined, right? Hip and knee replacement, tonsillectomy, hysterectomy, and CABG and spine surgery and PCI and CEA. These are all the ones on the prior slide where there's relatively low rates, but there's a high degree of geographic variation, which indicates that there's probably it's kind of a diffusion of innovation problem, and the innovation here is to not do these surgeries. They're not very effective. Radical prostatectomy causes a lot of problems for a lot of people afterwards. It's just not that effective of a surgery. So it may be that it's kind of reverse diffusal of innovation, where you're getting people are not doing as much, but in some places they're still kind of hanging on because maybe they've been doing it for 50 years and that's just what they know how to do. And because the rates are low, you see that there's high variation then in that. When you looked at just the systematic components of variation, and here I was able to look at US and the UK with some exceptions. Here again, systematic component of variation in France is on this axis, and that in the US or Britain is on this axis. US is an open circle, UK is a diamond here. And you can see that, and the dotted line again is kind of equivalence. So here, France has higher systematic component variation for these rare, much less common kind of events. And it's kind of a problem for France. This might be a real indication for intervention to identify who's doing these and tell them to kind of cut it out. Don't do so much of this with cabbage spine surgery and radical prostatectomy. So I think, in general, though, the numbers were fairly similar, fairly close to this line. France has a lower, the US and the UK have higher rates of hysterectomy. We don't have it really for the US, but the UK has a lot of variation in hysterectomy. But these are fairly close to the central line, except for these kind of outliers. So now we'll examine, so now that's kind of, we've done with the elective surgeries with just kind of the national geographic variation. Now we'll look at the roles of for-profit and not-for-profit hospitals in providing elective surgical care for these preference-sensitive conditions. And we're going to start with just the hip and knee replacement surgery, and also look at hip fracture as well as, again, a kind of a control factor here. And I'm just going to explain to you that usually when we present these things at Dartmouth, we present them in quintiles, right, which are 5 different groups. You just divide the 5 groups into equivalent numbers, and you present data that represent the mean of each of those groups, and you color code them. So in the graphics that I'll show you, if it's dark, it's a high rate, it's the highest rate, and as it gets lighter, it's the lowest rates in the country. So here's some evidence of procedure-specific geographic variation for knee replacement surgery and hip replacement surgery. And this is overall combining for-profit and not-for-profit hospitals. And this is for-profit and not-for-profit down here. And like I said, dark is a high rate and light is a low rate. And so at the national, you can see there's kind of these regional patterns, right? You see there's concentrations of higher rates that go beyond each of these kind of departmental level borders. And so overall, we found that overall knee replacement is higher kind of in the northeast and in the kind of the central west. And if you look, oops, let's see. And then hip replacement is higher kind of across the central area and maybe in the northwest as well. And if you look, though, at the for-profit versus not-for-profit, this is for-profit and not-for-profit, you see there are different patterns here as well, that the for-profits are kind of more concentrated maybe through here, and the not-for-profits are further on the eastern side. And it's a different pattern a little bit for hip replacement, where it's a little bit more to the west here and a little bit up higher here. So you can see that there's differences in the per capita rates of utilization in the different sectors as well. This slide shows the departmental, each dot is a departmental age and sex adjusted rate for a for-profit hospitals on the x-axis and not-for-profit on the y-axis. And we therefore hip fracture here, hip replacement, and knee replacement here. And this is for just patients 65 and older in 2009 and 2010. And first thing that we found is that patients are about 4 times as likely to get a hip fracture treatment, be admitted for a hip fracture in a not-for-profit hospital than a for-profit hospital, right? And that kind of makes sense because not-for-profit hospitals have about 80% of the beds, more or less, right? So you expect it to be, if it's just random, you would expect that to happen. What's interesting is that for-profit hospitals concentrate on these elective surgeries, right? This is their kind of business model. They do these elective surgeries, and you see the reverse here. You see 4 times the rate of admission on average to for-profit hospitals as you do for not-for-profit hospitals. So they've been effective at capturing the market largely. What you also see here is complementarity of the for-profit and not-for-profit hospital admission rates. And when not-for-profit hospital admission rates are kind of high, then the admission rates to for-profit hospital rate are kind of low, and vice versa, right? And these are kind of rates of admission to for-profit hospitals are high, they're low here. So I don't know if that's the for-profit hospitals. They've come in and they've identified regions and they kind of have captured the market for those regions and they just don't have as many beds in these other regions or what. The red dots are actually in Ile-de-France where there is kind of a different setting and there's a lot of referrals and it may be a different kind of setup. So if you were to eliminate these red dots, this would be a stronger relationship and one that you really don't see here in hip fractures. Okay, this is a rather busy slide, right? But it shows, this is the spatial regression results for the models that predict the for-profit admission rates on the top, and here the not-for-profit admission rates on the bottom for a variety of different variables that we thought were important. We found that, oops. So population density is positively correlated with rates of admission, particularly in the younger age group, to not-for-profit hospitals, and negatively so for not-for-profit hospitals. So where there's more population density, there's a higher rate of admission to for-profit hospitals, probably because the for-profit hospitals target those areas, right? They're more likely to be there, right? Here, the median income is negatively associated with, particularly in the younger age group, with the admissions to for-profit hospitals, and also negatively related here to the not-for-profit hospital admissions. So poverty seems to indicate that for these, you just don't get as many admissions, living in a poor area, right? And the most important finding is really that the number of beds, the per capita supply of beds, influences the admission rates, right? So where you have more beds, more for-profit beds, you have a much higher rate of admission to for-profit hospitals. When you have higher rate of not-for-profit bed supply per capita, you have a higher rate of admissions to not-for-profit hospitals. So basically they use what they use. They use what's available. Okay. So now I'm going to shift to how for-profit and not-for-profit hospitals differ in providing care for the broader set of elective surgeries, not just hip and knee replacement. For-profit hospitals, when you look at that, they found that for 9 of the 7 procedures, the patients are much more reliant on for-profit hospitals than they are for not-for-profit hospitals. And this varies, so this is kind of double for tonsillectomy. It's double for, it's close to double for hip replacement, it's double for TURP, it's double for radical prostatectomy, it's double for spine surgery. So there's a lot, even though not-for-profit hospitals have about 80% or more of the beds, for-profit hospitals are capturing a large proportion, 2/3 kind of the market for certain of these things, these procedures. When we look at age, the age differences across them is not very different, and the male distribution is not really different. So age and gender don't really matter. It's not as though the for-profits are targeting a particular age group or gender. What we do find is that the for-profit hospitals tend to have both lower lengths of stay, considerably lower length of stay. The exceptions here are in red, so there's just a couple of exceptions of length of stay, and they have a higher rate of diagnoses, and again, the exceptions here. So for all but 2 of these in either column, that's the case. Shorter length of stay and higher number of diagnoses. It's unclear why they have a higher number of diagnoses and a lower, I mean, it's kind of counterintuitive. Everything you would look at in the US, you would find higher rates of diagnoses are predictive of higher, longer lengths of stay. So this may be a coding factor, may be a way to generate more revenues. We found in the US there's a lot of variation in the way people diagnose and what diagnoses they use, and that tends to be associated with reimbursement efforts. Okay. So if you look at, now we're looking at the reimbursement structure for these same conditions, and we're looking at the type of hospital and the different reimbursement kind of category, and there's physician, structural, clinical, and direct, and then a total. And so they're calculated differently, as maybe you know, where the physician costs are being, they're separately identified in the for-profit hospitals, and they're largely kind of aggregated into the clinical and direct costs in the not-for-profit hospitals. So there's a difference there, but we see when you look at the physician component, then the for-profit hospitals are always larger, right? Because they bill separately and they don't embed it in the billing practice. So you would expect that, and it's a lot different. When you look at the clinical and direct, it's just the opposite. You see that not-for-profits are a lot higher. Generally, that's because they're embedding their physician practice costs in there. But when you look at total, when you look at total, the mean reimbursement per admission to not-for-profit hospitals is considerably higher than that for-profit hospitals. And it's over 60% higher for tonsillectomy and spine surgery. So there's a big difference here. And spine surgery is something that the for-profits actually concentrate on. The only exception that we found at all was percutaneous coronary intervention, where for-profit was higher than not-for-profit by a few hundred euros. Now, the next slides I'm going to look at, so one concern might be that we raise is that there may be a different threshold for admission to for-profit hospitals than not-for-profit hospitals. And this might be undoing some of the efforts to contain costs that the for-profit hospitals are supposed to actually accomplish. To understand this, it's important to note that the DRG-like accounting system has different levels of care, right? There are different levels that are reimbursed differently, and they indicate different levels of complexity. They tend to go from niveau 1 to niveau 4 or 5. And so lower complexity care, you get paid less, and higher complexity care, you get paid more. And so this is an example here of how cases might be distributed across 3 complexity levels in not-for-profit and for-profit hospitals. And here just the example is that the for-profit hospitals have twice the number of cases as not-for-profit hospitals. So here's twice the number. And we're just distributing these equally, right? So it's twice in every category. And this is what you would maybe expect if there's no difference, right? So to look for differences in the distribution of cases across levels, we calculate 2 measures: the relative risk of for-profit hospitals having a higher proportion of the lowest complexity levels, and also the ones having a higher proportion of the highest complexity, right? If they had a higher proportion of the lowest complexity, you might think that was they were admitting patients with a lower threshold. They just saw more low complexity patients. Vice versa, you might wonder whether or not they are like kind of over-diagnosing and over-billing potentially. So here you would find the relative rate of the low is 1 and the relative rate of the high is 1 in this, because it's the same, right? It's the same distribution even though the numbers are different. In the second example, we're going to have the for-profit hospitals have a higher proportion in the lowest niveau, right? And a lower proportion in the, or just the relative, a higher proportion in the lowest niveau. And the relative rate of a for-profit having a higher proportion in the lowest niveau is then higher here, and it's lower in the high niveau. And similarly, if we did the opposite, we would have a higher proportion in the highest niveau, and we'd say that the relative rate of the for-profit in the high niveaus would be higher here, right? So we're just looking at the distribution across the country, not at the individual department level, but for everything for these different niveau levels, the different levels of complexity. And using these measures, we found that for-profit hospitals had a higher relative rate of admission of the lowest complexity niveaus, so the lowest levels, and a lower relative rate of admission for the highest niveaus for tonsillectomy. So here they have both. They have lowest and lower of the highest. And this seems to indicate that they might over-provide tonsillectomy services. Recall they do twice as many as in the not-for-profit sector. And this is probably generally thought to be largely an unnecessary surgery for most kids. We also found lower relative rates of high complexity niveaus for cholecystectomy, spine surgery, and PCI, percutaneous coronary intervention. These are all statistically lower, and they don't cross the interval. And this may suggest, this is a little perplexing because of for-profit hospitals, they have more secondary diagnoses. And so this may indicate that they're overcoding secondary diagnoses, right? Because they're entering them into the lower complexity ones, but they're saying that they have more diagnoses, so maybe it's just a coding issue where they're just incentivized to code more. Second here, we found that, and the red ones are obviously in the statistically significant ones. For-profit hospitals were more likely to have reimbursements for the lowest niveaus for hysterectomy, hip replacement, knee replacement, and radical prostatectomy over here. And the greater number of secondary diagnoses may help explain the results for hysterectomy and radical prostatectomy, which don't have the lower reimbursement procedure differences. But results in the hip and knee replacement are difficult to understand, again, in light of their shorter lengths of stay. You would have thought that they would have longer lengths of stay with this kind of pattern. So these findings in aggregate suggest the possibility of upcoding for hip and knee replacement in the for-profit sector, and that maybe should be investigated further. But one caveat for all of this analysis is that the interpretation is really predicated on the assumption that not-for-profit hospitals don't over-admit or over-diagnose or upcode at all. So we're assuming that not-for-profit hospitals are totally legitimate and they're the standard, and that we're just comparing to for-profit hospitals here. So now I'm going to go on to geographic variation in rates of admission for ambulatory care sensitive conditions. These are the ones where if we could avoid them, they're potentially avoidable and we might potentially save money, and we'll see how much money we might save. This shows variation in department level age and sex adjusted rates of admission for ambulatory care sensitive conditions in 2009 and 10. And these down here are the calculated rates and low, high, extreme ratio, interquartile range, coefficient variation, and systematic component variation for ambulatory care sensitive conditions. We use the British system of aggregating these. If you look at ambulatory care sensitive conditions, there's a whole bunch of them, but that means the rates are very low and the systematic component variation would be very high. So we aggregated them similar to the British system, so we could also compare across different countries to those that are vaccine related, acute, and chronic, things like, so acute is things like pneumonia, a sudden pneumonia that could have been prevented just by better care. Chronic is congestive heart failure, angina, things like that. And vaccine related would be some flu or something like that that might be avoided, or some admission for a kid that might be avoided by a vaccination. We also, just because we were interested in it, looked at alcohol related and so-called other ones, other ambulatory care sensitive conditions that were described in the literature, but did not fall into the three categories that the British used to present their data. So for vaccine, and these are the three British ones, and these are the non-British ones. And here we find that actually the systematic component variation is very low for these. It's fairly tight, even though the graph shows maybe it's higher over here, except for alcohol, where it's a higher rate of, for alcohol-related admissions, there's a lot of geographic variation that you see in France. Okay. And you see, though, however, there are trends upward in all of these except for vaccine-related ones as well. So over the couple of years, the ambulatory care sensitive condition admissions are going up, which might be a little concerning, suggesting that you could drop the admissions. Here's some regional patterns. These are chronic, acute, vaccine preventable, alcohol-related, other, and total. And you can see that there are different patterns for the different categories, really. The northeast part of France had relatively high rates of admission for chronic ambulatory care sensitive conditions. Northwest had relatively higher for alcohol-related. And no one is surprised when I show this, I guess, right? Because this is a known thing. And southern and northeastern kind of France had higher rates for other ambulatory care conditions. And over here, the concentration is kind of to the northeast overall. But that's probably because the chronics is a much higher rate, remember. So it's driving this whole other analysis, right? Total analysis, rather. So they were higher rates of admission for chronic vaccine preventable and alcohol-related ambulatory care were related with a greater bed supply. So here's the allocated medical beds per capita, and you see that for chronic it's higher, and for vaccine preventable and alcohol it's all statistically different and higher. So where there are more beds, you get more admissions for these, which is kind of a supplier-induced demand concept, right? What we didn't find, that we expected to find, was general practitioners per capita. We found that there was a negative effect, so where there are more of those, there are fewer alcohol-related admissions, but not for the others, not statistically so. And in most of the literature, you find actually that that's the case. There's this inverse relationship. Here we're looking at comparisons across countries. And we see that in comparison to everyone except for Brazil and the United States, France had actually a much higher ambulatory care sensitive condition admission rate. So that could be a little disconcerting that you're using hospital resources that are kind of expensive for admissions in France, and that could be disconcerting. When there was a recent paper that just came out as well that indicated kind of the same thing, that France has a considerably higher rates of admission. And what we did here is we used whatever method of determining ambulatory care, of identifying and including criteria with age and gender and all that. We used that to mimic their results, and these are the findings we got. When you look at admissions for ambulatory care sensitive conditions, they consumed 7.9 million bed days of care in 2009 and 8.7 million bed days of care in 2010. Most of these are in for-profit. These are the for-profit, not-for-profit hospitals are the big ones. So it's not-for-profit hospitals that are bearing the brunt of this. About half of the bed days consumed are due to the black, which is chronic, which makes sense. It's the biggest amount. And so you can conceptualize this as each year these admissions for ambulatory care sensitive conditions are consuming, it would be the equivalent of a 255 bed hospital running at full capacity just for this in each department in France. So that's a lot of beds and a lot of utilization that could be, hypothetically, this is all unneeded, right? From a cost perspective, costs over 4.7 billion euros in 2009 and over 5 billion in 2010, increasing about 6.5% over the 2-year periods. Again, chronic is about half that cost. And these reimbursements were more than half of the French healthcare system deficits in those 2 years. So this might be an area to focus on, to think about for policy. So in summary, we found a lot of geographic variation in rates of admission for common surgical procedures. France had lower rates of most of those admissions, but measures of variation were about the same, except for when France had those much higher measures of variation in those kind of less common procedures. France had less geographic variation for ambulatory care sensitive conditions, except for alcohol-related, where the variation was very high, but it's got higher rates of admission for ambulatory care than most other ambulatory care sensitive conditions than most other countries, and there's a lot of resources that were consumed, and those rates appear to be going up. Admission rates for hip and knee replacement were correlated with sector-specific beds, and those for several ambulatory care sensitive conditions were correlated with higher bed supply, but not general practitioner supply. And we found potential indicators of overuse of care, overdiagnosis, and upcoding of procedures in the for-profit sector. We have some limitations. The data we had are just the data we had, and so there could be errors in them. And these are just the initial descriptive statistics, so we can't prove causation here. We use departments, and other methods might use, I know Pierre uses smaller areas as well, and so other methods might might generate different results. And we were really unable to determine whether the elective interventions, the elective surgeries were justified or not, and whether the ambulatory care sensitive condition admissions were justified. So that's a big question here. We're assuming in the latter case that they're kind of not justified. We don't know in the former case of elective surgeries whether they're justified. And we didn't really have access to health status. Some people have suggested that we use mortality, but it's hard to think that mortality rates have anything to do with getting a hip replacement surgery or an elective knee replacement surgery. So what we are concluding is really the variation should be tracked and monitored just for the purposes of quality improvement and monitoring efficient resource utilization over time. And this, if you monitor this on the departmental level, as I said earlier, you might be able to target interventions for high utilizing areas and actually have cross department collaboration where the low utilizing areas could tell the high utilizing areas how they do it differently. Then maybe we should look at different conditions and treatments. It looks like ambulatory care sensitive conditions might be a priority. Development of some guidelines might help reduce variation, and admissions to not-for-profit and for-profit hospitals should probably be monitored over time, particularly as the competition kind of intensifies there. Next steps, we're in the process of updating with more recent years. We might want to figure out how patients in high and low use regions have different preferences. Someone named Holly in Canada has done a lot of work, and they found that there's a lot of variation in patient preferences for such care. We might look at the same thing for physicians, and there's methods you could do that using surveys and vignettes where you simply ask physicians how they would treat someone, and you can see in the US we found that more aggressive treatment is usually found in places where there's higher resource consumption. And we might implement shared decision making to try to overall reduce the variation in care. And that's all we have. So thanks very much for sitting through this. And thanks again to these groups for having me here, and to Bruno, Alan, Marie, who left, and Jean-Charles for helping do this work. I appreciate it. Thank you.
Thank you.